Hello, everyone, and welcome to another activity of our special series, Through the Looking Glass, Seeing a Better Future in Inflammatory Bowel Disease. I'm Dr. Aline Charabaty, Associate Professor of Medicine at Johns Hopkins School of Medicine, and the Medical Director of the Division of Gastroenterology and Hepatology, and Clinical Director of the IBD Center at Johns Hopkins Sibley Memorial Hospital in Washington, D.C., and founder of Monday Night IBD. I'm joined today by my wonderful colleague, Dr. Robert Battat. He's an associate professor at University of Montreal and the director of the Center of Clinical Excellence and Translational Research in Inflammatory Bowel Disease, Centre Hospitalier of Université of Montreal. Robert, welcome.
Thanks for having me, Aline.
I'm very excited to have you today. And before we dive into our topics for today, if you haven't reviewed our earlier activity in this series, focus on IL-23p19 and also focus on how we are advancing our management of inflammatory bowel disease and monitoring of disease, please visit the Bonum CE website. All these Monday Night IBD activities are CME accredited and certified, and this is jointly provided by PACE and Bonum CE. And this activity is made possible with the support of an educational grant from Lilly. Our disclosures are shown on the screen. If you haven't done so, please complete our pre-activity survey by clicking the link below this video or by screening the QR code. Let us know who you are and make sure you complete your evaluation at the end of the session and claim your free CME credits. And of course, follow our handles at Monday Night IBD and at Bonum CE and set your alert notification for more CME certified programs. So for today, we're going to focus on evaluating the data on the clinical efficacy and safety of the newly approved anti-IL-23p19 therapies in patients with ulcerative colitis. So Rob, let's jump right into it. Before we start talking about IL-23p19, can you tell us briefly what is the difference between anti-IL-12/23p40, mainly Guselkumab, and the newer IL-23p19 therapies?
So both are monoclonal antibodies. One, the older version, such as ustekinumab, they bind the P40 subunit, which is common to both IL-12 and to IL-23, and inhibit them. The newer versions, the P19 inhibitors, bind solely to the P19 subunit, which is specific to IL-23. So these are really IL-23 specific monoclonal antibodies. And the idea behind it is that perhaps if IL-23 is more implicated in disease activity in IBD, that you may get a more potent inhibition of that pathway.
That's fascinating. So blocking two cytokines is not necessarily more effective than blocking the one that's more relevant to the inflammatory process. Let's go over the data together and review what we have for IL-23p19. And before you start, I want to remind people what were the definition of clinical remission and endoscopic improvement in the trials of IL-23p19 in UC. Clinical remission was defined as resolution of the symptoms, so stool frequency of 0 or 1, no rectal bleeding, but also having an endoscopic Mayo score of 0 or 1 without friability. And for endoscopic improvement, it was defined as a Mayo score of 0 or 1 without friability. So, Rob, the floor is yours now.
Mirikizumab was tested against placebo in a classic re-randomization trial. So patients were given either placebo or mirikizumab, 300 milligrams IV every 4 weeks during induction until week 12. And then the responders were then re-randomized to receive placebo or to get mirikizumab every 4 weeks. At induction, in the overall population, clinical remission was higher in mirikizumab than it was in placebo, and that achieved statistical significance. So what that means is that overall in a global population, even after as early as 12 weeks, you were able to get both symptomatic resolution and a Mayo endoscopic score, so an endoscopic remission of 0 or 1. When breaking that down, the induction data, into bio-naive patients as well as bio-exposed patients, we see that the differences are greater in bio-naive patients than they are in bio-exposed patients, but you still do see a difference in the bio-exposed population. And then when you carry over into the maintenance trial, at the end of 52 weeks, again, in the overall population, you're able to get both clinical remission, which is a symptomatic endoscopic joint score, which is greater in Miri than it is in placebo. And you see that separation that actually now looks quite similar, if not even better in the bio-exposed patients, just took a little bit longer to get there. So you see a separation of bio-exposed patients of a delta of 30% versus placebo. And actually, you see in bio-naive patients, that delta is about 20%. So overall, the message is that by the end of 1 year, this drug is efficacious in both bio-naive and bio-exposed patients to hit both symptomatic and endoscopic endpoints. And then we even have long-term data, so the LTE, the long-term extension data. And what you see is at the end of 3 years, that if you're in remission, you're able to keep that remission. So there is this durability of the class in general that we see in both UC and Crohn's. And then when looking at just endoscopic data alone, again, you see that at the end of a year, you have essentially a doubling in the treatment arm.
Thank you, Rob, for going over this. So just to kind of take it a step back, and I'm glad you pointed out that, with clinical remission at induction, it's both symptomatic remission and endoscopic improvement. And I think most of us in practice, we don't scope patients as early as week 12 after the induction. So the symptomatic remission rate is higher, but of course, waiting for that endoscopic remission takes more time, and that's what we're seeing during the maintenance phase. So again, I think at first view you might think, okay, for bio-exposed, the clinical remission is less than the bio-naive, but like you pointed out, when you get to the maintenance, you see very similar result in both the bio-naive and bio-exposed, and a higher delta in the bio-exposed. So how do you apply this this data in your practice? Do you give more time for your bio-exposed patient to assess them both clinically and by endoscopy? What do you do in your practice, and in terms of explaining to patient also that once we're there, we're also going to have a very durable response, which is often the worry of patient. They ask often, I'm feeling good now, but is this going to continue to happen? So how do you put this kind of data in your practice?
In terms of pure efficacy discussion with the patient, again, like you said, we don't scope our patients like in a month or 2 or 3 right after we start an agent. I think what we're looking for is that the patient feels better and that there's some objective proof of improvement, so a fecal calprotectin reduction or whatnot. When looking at even within this trial, the clinical response rate, meaning the improvement in symptoms, was significantly higher with mirikizumab during induction. And that's what you want. You want them headed in the right direction. And then, obviously, by the end of a year, you want them to have achieved the treatment target of getting into, of healing the organ, so getting into endoscopic remission and having no symptoms. So that's what I tell my patients is that, if you have, in bio-naive, it's an easier discussion because it seems to work fast to get you in the most, deepest form of remission. But in bio-exposed patients, you will start feeling better over a period of months. And by the end of the year, we aim to get you, nearly perfect. And that once you get in that, what's nice about this class is it seems to be a durable remission. So we hope that you're going to be in remission for a long time, given that this is a lifelong disease.
Absolutely. And, looking at if we can go to the risankizumab and Guselkumab data, it seems that we have the same kind of pattern where at induction, patients who have been bio-exposed have a decreased clinical remission compared to those who are bio-naive. And then things change during maintenance. Can you walk us through those two trials, and then And then I'll ask you, how do you put everything together in your practice?
Yeah, so I'll start with the Guselkumab just because it's somewhat more analogous to the Mirikizumab data. So again, the trial design is the same. It's a randomized induction and then a re-randomization after induction. And the conclusions are somewhat similar as well. So the change of drug versus placebo is very similar, overall. And then in the bioexposed patients, the delta after induction in the MIRI trial was 7%, and in this trial was 9%. So we see that overall there's a small but numerical difference in the P19 versus placebo after induction in UC. But then when you get out into maintenance, in this trial is week 56, you see again a nice separation between guselkumab and placebo, similar to what you saw for mirikizumab. Again, you also see the endoscopic data for guselkumab that's more than a doubling versus placebo in terms of endoscopic improvement, getting to a Mayo endoscopic score of 0 or 1. If we move over to the risankizumab data, the induction data and the trial design is the same. The induction data, particularly for bioexposed, looks again similar to mirikizumab. The only difference here is that while risankizumab does work well, the data show that it was effective in bio-naive patients for achieving clinical remission at the end of 64 weeks. In the bioexposed patients, in this trial, there wasn't a significant difference for risankizumab versus placebo. So that would be the only difference in terms of this drug within the class. But for Gus and for Miri, I think the conclusions are identical.
Thank you so much for this review, Rob. So, how do you put this data together in your practice? Let's start with, in a, how do you approach the different choices that we have when you see a patient with newly diagnosed ulcerative colitis, a bio-naive patient? How do you think through the different MOA and how do you make the right choice for the patient?
Yeah. So in a bio-naive patient, so in all patients, I think some of the considerations are is this patient bioexposed, right? So that's the first consideration. We're talking about bio-naive patients. And then you look at um, the severity spectrum and you see is the patient lie, in the true moderate to severe, kind of the majority of the patients, or do they lie on the extreme end of the spectrum where they're, at the severe? And then do they have extraintestinal manifestations? Those are the major considerations in UC in terms of selecting an agent. So in the bio-naive patients, we're, in the true, well, if we go out to the extremes, if you have the most severe end of the spectrum, those patients you're typically thinking about TNF antagonists, given their data for acute severe UC, as well as JAK inhibitors in that context. Again, if JAK inhibitors are not available to you, then you're thinking more in the TNF antagonist, for bio-naive patients. But in the vast majority of patients, then you're, thinking between a P19, a P40, and vedolizumab. And so how do you, choose between these agents? One of obviously the considerations is, then you can go to extraintestinal manifestations. So if you have, other extraintestinal manifestations such as like axial spondyloarthropathy, you may consider using a TNF antagonist or a JAK. If you have psoriasis, you may use a P40 or P19. And if you don't have any of them, you may consider vedolizumab. I think that one of the favorable points for the P19 that kind of tend to push me towards that class now is that in the trials, so in the trials for the P19, the absolute numbers, we're not supposed to compare, trial to trial, but it generally looks better than the P40 data for UC. But compared to Vado, the Gemini trials for Vado looked great. I think the issue is that the overall population in terms of sickness of the cohort was somewhat less sick than the populations that were included in all the P19 trials. And so if you're showing similar deltas, but the patients were sicker, then it just tends to elude that maybe the drug works a little bit better. And then Another, to me, very important point in this is patient preference. So, there are some drugs, right? So, say vedolizumab, you can have an IV infusion every 8 weeks or every 4 weeks, or you can have a subcutaneous dose every 2 weeks. With the P19s and the P40s, you can have essentially sub-Q every 8 weeks, which is, in terms of preference, I think a lot of patients do prefer that. So 6 injections subcutaneously at home by yourself a year versus sub-Q every 2 weeks, which would be 26 injections every year versus going to an IV infusion center. So I think that's another consideration that patients tend to, gravitate towards that convenient factor as well.
And in terms that was very helpful, and thank you for going into all these details with us. And it seemed looking at the data that for bio-naive patient, if you choose
Yeah.
an IL-23 P19, for me, looking at the data, I wouldn't have any preference between the different agents.
Yeah.
It seemed they perform very similarly. Again, like you said, recognizing that we cannot compare trial to trial.
Yeah, so and so in saying P19, I kind of maybe glossed over it that I don't really have a preference for one or the other in bio-naive because the totality of the data look similar. And so I feel that the data is equally strong for all three P19s in bio-naive ulcerative colitis.
So moving to bio-exposed patient, and I agree with you, the very severe, we tend to think infliximab and JAK inhibitor, but in the more common moderate to severe, how do you approach therapy here again in a bio-exposed patient in terms of the different treatment choices, another anti-TNF, IL-23, P19, the P40, isticulimab, and Vido? And do you see a differentiator with the IL-23 class?
Again, excluding, the most severe patients, excluding patients with axial spondyloarthropathy or other indications for TNF or JAK inhibitors. One of the, and obviously you have psoriatic diseases. So obviously if you have a patient with psoriatic diseases, psoriatic arthritis, psoriasis, this is obviously an ideal candidate. And I think that really, in terms of that combination of convenience and efficacy in bioexposed, particularly for Miri or for Guselkumab, you have a very convenient option where you can take a drug every 4 to 8 weeks by yourself versus having to go to an infusion center indefinitely. So I think that that's a differentiator. And then also I think that the robustness of the data in bioexposed, like it's a sicker population, so you feel more comfortable, and more confident telling a patient who's bioexposed, that, versus say vedolizumab. Here you can say, well, this was quite a sick population, and in the patients, these many patients who were bioexposed, this drug did work. And it eventually got you to that point. I do think that it's important to tell the patient that that may not be after, you may not be perfect after 4 months, but after a year, there's a very good chance that you get there. And so with a patient who's bioexposed, there's a little bit of a different way that you need to speak to the patient. You have to say, that we aim to have improvement after several months. That means you feel better, and that we've measured some form of either blood test or stool test that has improved, not perfect. And then by the end of a year, we aim to have you without, diarrhea, without rectal bleeding. And when we look at the organ, when we do a colonoscopy, we see that your organ is healed. So with a Mayo endoscopic score of 0 or 1.
Thank you again, Rob, for this very insightful review of the most recent data that we have on IL-23 P19 in patients with ulcerative colitis. And so just to summarize a few points and what I gather from this conversation, these are drugs that are highly effective and safe. But we hadn't had a chance to talk about safety, but we talked about it in our Crohn's disease segment, and we don't see any different safety signal in the patient with ulcerative colitis. We reviewed how you approach treatment in patients with bio-naive, the very severe, thinking infliximab and JAK inhibitor, the more moderate, looking at associated comorbidities such as psoriasis and psoriatic arthritis, where P40, IL-12, IL-23, P40, isticulimab, and 23p19 could be a good options. And then for mainly luminal disease, vedolizumab is also a good option. Looking at the data, it seems that all three IL-23p19 available to us have similar efficacy in terms of clinical remission and endoscopic improvement. Looking at bioexposed patient, we might see here more of a differentiation with Miri and Guselkumab, with bioexposed patient doing as well as bio-naive in the maintenance, but recognizing that it takes time for bioexposed patient to reach that level. And I love the way you approach that, Rob, in terms of setting realistic expectation for patients who have been bioexposed and not promise them they're going to feel great right away. And so we do need to give more time for bioexposed patient as long as we see improvement in symptoms and biomarkers of inflammation, and really relying on this data to guide our management. Anything else, Rob, that we need to add before we conclude?
No, I think that's it. I think we said enough, and thank you for having me.
Thank you so much for being here. Thank you everyone for joining us. Please make sure to obtain your free CME credit by completing the post survey and the evaluation on the links below or by scanning the QR code. Have a great day.